आ गया सर.
Yeah, देखिए.
Is fine now?
Yeah, perfect.
So my presentation is titled Gas Wala Headache, because you realize when people present to you with headache, they can present with many types of symptoms, and they can be strange symptoms like gas is going into my head, a bomb is bursting in my head, a sharp needle is piercing my head. So there are various presentations of headache which can confuse us. So this presentation will use certain cases to try and explain various causes of headache and then move to investigations and treatments. How frequent is headache? We say headache is khani ghar ghar ki because in a survey in America, almost 1% in four households had one migraine sufferer. Malab, around us in this presentation also there may be 10 people who may suffer from migraine. And worst part is, the paradox is, headache being so common, the headache is neither taught in MBBS nor in MD and not even in DM of neurology. Because we don't think headache to be so significant a problem, but in clinical practice, headache causes biggest headache both to the patient and the doctor. And we learn about headache when we read or practice medicine rather than in our formal teaching. So the most frequent cause of headache is migraine, and you have read hundreds of prescriptions labeled known case of migraine. So the basic story is to differentiate various headaches from migraines. So we will go through few cases to try and understand various clinical presentations and then try to differentiate these cases from migraine. A very common OPD story is a 30-year young lady comes to you. She says, मेरे सर में 6 महीने से डेली दर्द है, टेंशन है, टेंशन से बढ़ता है, चिड़चिड़ापन है, थकान है, पूरे सर में बेचैनी है और कुछ अच्छा नहीं लगता. Everybody must have heard it multiple times. So what do you think is the diagnosis? Anybody? What do you think is the diagnosis? What test to do? Lot of you're on mute.
Probably it is depression, and we don't need any test.
Very good, sir.
It can be a clinical diagnosis.
It can be tension type headache with depression, or it can be migraine also, because a lot of women may have history of migraine, and migraine can cause depression in 30% people. So a person who has chronic headache can appear as depressed. Until you take detailed history, you will not realize what type of headache it is. So the headache diagnosis, as Dr. Pawan rightly said, usually cannot be made by test. Infrequently by examination, it is made on history. So even this patient, you only hear this and make a diagnosis, you will say it is depression. If you ask her what causes her headache, what are triggers, when did it start, you may find that the diagnosis may be migraine with depression, with tension type headache. And one person can have two types of headaches. It is not necessary that one person has to have one headache. A person can have migraine and cluster headache both together. So it is for the doctor to find which is happening. The other thing is, most people think if they have headache on hunger, travel, sunlight, it is normal. But there is nothing called normal headache. If you have pain, it is never normal. You have to identify if somebody has pain, what is causing it. So because people think it is normal, they don't report it also. You have to elicit it. A 60-year-old lady comes to you with history of intermittent headache, severe for last 6 months, which improves with analgesic, with photophobia, with numbness in head and difficulty in concentrating. So when a 60-year-old lady comes, should you do the MRI? So in older people with headache, you should always do the MRI, even if the headache appears migrainous. Thankfully, her MRI of the head is normal. What would be possible diagnosis in a 60-year-old for headache? Can it be migraine, some other diagnosis with a normal MRI? So what questions can we ask? What tests we do? One, unlike contrary belief, older people can have migraine. And if you don't take the history of younger days, you may think it is a new onset headache, but the patient may have headache all her life. which may improved during menopause and came back again. But the most salient headache in a person like this is called temporal arteritis. The most serious headache with a normal MRI in an elderly person is called temporal arteritis because it can cause blindness and stroke. The basic diagnosis test which can confirm it are temporal artery biopsy and temporal artery ultrasound. And on examination, absent temporal artery pulsations. But the simplest test of an elderly person that you must do is ESR and CRP. Very low cost, but if the ESR and CRP is very high and the headache is not responding to your usual medications, please suspect temporal arteritis or giant cell arteritis. So a 30-year-old lady comes with 2 episodes of headache in last month, which is unilateral throbbing, accompanied by vomiting and improved by sleep. Anybody, what do you think is the diagnosis?
Most likely migraine.
Migraine.
Migraine. So this is not migraine, it is migrainous headache. I'll tell you why. Migraine is chronic disorder. A person who has 2 headaches should not be labeled migraine because in short history, anything can appear like migraine. And it can be secondary migraine headache. So writing known case of migraine too early can make you miss very, very serious diagnosis like subarachnoid hemorrhage. Because subarachnoid hemorrhage can have sentinel headaches. Colloid cyst of the third ventricle, absolutely treatable life-threatening condition. Pachymeningitis, a form of meningitis that can happen without fever. So if the history is short, keep your mind and diagnosis open. A 30-year-old gentleman presents with innumerable episodes of unilateral headache with photophobia, with nausea lasting for 1 hour for last 10 years. What do you think is the diagnosis?
This is migraine.
Sir, this is what questions will you ask? Most important thing, sir, is diagnosing of headache. A migrainous headache has to be usually for more than 4 hours.
Achha.
Any headache less than 4 hours is usually less than 4 hours is not migraine. Very important thing. So 5 minimum headaches to diagnose migraine. Headache has to be for more than 4 hours. It can be from 24 to 72 hours. This is most likely to be cluster headache. Men have 8:1 ratio of cluster headache, in which all other tests are normal. The pain lasts for 1 hour. It is always on one temple, associated with redness of eye, watering or blocking of nose. Typical symptoms of cluster headache. Comes like clock. Every day come at the same time. Also called suicide headache because it is so bad that the person wants to bang his head in the wall. Or there is another type of headache called idiopathic short-lasting headache, which is a variety of primary headache disorders where there is sharp, short-lasting pain lasting from few seconds to minutes. Many of these headaches respond to indomethacin, which is a drug of choice for many type of primary headaches, which are short-lasting headaches. Idiopathic stabbing headache, then there are sung, suna, paroxysmal hemicrania. Then there are other types of primary headaches like paroxysmal hemicrania, episodic hemicrania, which are primary headaches different from migraine. Another gentleman comes to you now with 2 episodes of unilateral headache with nausea, with photophobia lasting 10 hours, preceded by blurring of vision. What is this headache, sir? Sir, from surface, most headaches look similar because patient only gives similar history. Yes, sir?
SOL?
Sir, it can be an SOL. So in India, it can be occipital lobe, NCC or tuberculoma also, which is causing blurring of vision. But it can be migraine with aura. Migraine with aura has typical blurring of vision for first 15 to 30 minutes, followed by headache. So if somebody has recurrent headaches preceded by blurring of vision, it can be migraine with aura. Aura of migraine can involve numbness, tingling, even hemiparesis. which is called familial hemiplegic migraine, or sometimes it is called basilar migraine. A 30-year lady presents with a history of unilateral occipital headache with pain starting in neck, rising to head, then spreading, lasting up to 2 days with numbness and paresthesias in arm. What do you think is the diagnosis? And what test will you do? Pain in the neck radiates to arm, numbness, last 2 days, spread from back of neck into head.
Vertebro-basilar syndrome.
What else? Cervical spondylitis,
Cervical spondylosis.
cervicogenic headache.
Yes.
You do a X-ray which shows cervical spondylitis now. Do you get a MRI done or you don't get a MRI done?
We should do it.
So even if you do the MRI, it still shows cervical spondylitis, but it is not cervical spondylitis because the pain lasts for 2 days. It has triggers. So cervical spondylitis does not have triggers and the pain cannot last for 2 days and then disappear. If it comes by sitting. It has neck muscle spasm, difficulty in moving neck, and does not have light sensitivity. And the only trigger is overwork in sitting posture. So until you take detailed history, because migraine can start at the back of the head also. It doesn't have to start in the front of the head always. So cervicogenic headache can only be diagnosed when the patient have neck spasm, stiffness, difficulty in moving neck, no light sensitivity, and trigger is overwork in sitting posture. But cervicogenic headache can also trigger migraine in susceptible people. A 30-year-old lady presents with visual blurring which is transient as she rises up from sitting position with severe headache. Last 3 months, 5 to 7 episodes with nausea. What do you think is the diagnosis? Is it migraine or not migraine?
Appears to be migraine.
Migraine with aura, migraine without aura?
It is with aura.
What is the most important test that you will do in this person?
Fundus examination.
Fundus examination. The most important test in a person who has headache, which is even more important than MRI or CT, is fundus examination. So you did fundus examination, he has papilledema. So when you hear of papilledema, you think patient has tumor and you are worried. But most middle-aged women who have papilledema have benign intercalated hypertension, or what was known as pseudotumor cerebri. This is classical history of pseudotumor cerebri. When patient changes position, there is visual loss due to pressure on optic nerve called transient visual obscuration. So single most important test in headache is fundus examination.
Yes.
A 45-year-old gentleman presents with transient blurring of vision with complete inability to see for 20 minutes. He had the same episode 3 days back in office, but he has no headache. What do you think is the diagnosis? What test will you do? Will you do MRI? MRI, angio, EEG?
First of all,
MRI should be done immediately.
Fundus is normal.
Fundus examination to
Fundus normal, sir.
CRVO or CRVO.
Fundus is normal, sir. Eye
MRI
examination is
should be done.
normal. You did MRI and you did MR angio, it shows 30% left ICS stenosis. EEG is normal. What do you think is the diagnosis? Is it TIA? Can it be TIA?
TIA can be there.
It can be TIA. But sir, it can be migraine aura. There is migraine aura that happens without headache. It is called aura sans migraine. And when we proceed, I will tell you how to differentiate migraine aura from TIA. There is one very important history. In migraine aura, the visual loss is like a curtain. It comes like a curtain coming in front of your eyes and it goes like a curtain going off a stage. In TIA, it is sudden. This is a change that can only be made on history if you know this. Otherwise, this diagnosis cannot be made. Another person comes. Yes, sir.
It is usually focal visual loss.
So it can be complete also, what is known as emesis fugax.
Yeah.
But it has to be sudden onset, sudden offset. Migraine is a curtain-like onset, curtain-like offset. No test can find that out. A 40-year-old lady presents with 6 months history of headache with vomiting. When she is brought to ER, her BP is 150 by 100. She has 3-4 readings which show her BP to be in the range of 160 by 110 to 150 by 90. What do you think is her diagnosis?
Hypertensive headache.
Sir, blood pressure during headache is not sufficient to diagnose hypertension, because when you have any pain in the body, the BP will be high. All such patients should be required to maintain a diary of BP when there is no headache. If she has normal BP during interictal period, then she does not have hypertensive headache. Her BP is raised because of headache. And if you put such patient on antihypertensive, the patient may have syncope, because such women may have low blood pressure also. Hypertension usually does not cause headache. In most people, hypertension, routine hypertension, is an asymptomatic disease. It is only when the BP crosses 160, 110, 180, 110 do you get severe throbbing headache in most people. So a 40-year-old lady presents with 1 year history of headache, stress in family, sadness, crying and withdrawn behavior, and starts crying in OPD while narrating history. What is the diagnosis? It can be tension type headache with depression.
Depression.
So the commonest headaches are migraine, tension type headache. Other usual headaches are primary headache disorders like short-lasting headaches and cluster headache, commonest headaches. So how do you diagnose migraine, which is the commonest headache? The diagnosis of headache only depends upon patient history, because frequently examination and MRI are normal. How frequently MRI is normal, I will tell you. So the criteria for diagnosis of migraine are, the important pointers are onset before 45 years, presence of aura, menstrual association and family history of migraine. Migraine aura is a thing like bright dots, flashing of lights and zigzag lines. These symptoms can occur before or during the headache. But you diagnose migraine by criteria called sultans. First criteria is severe unilateral throbbing activity worsens headache. 2 from this list should be there. And second criteria is nausea and sensitivity. 1 from this should be there. If you have these criteria and you have 5 headaches of this type, then you can diagnose patient comfortably as migraine in most cases. But important thing is, during migraine attack, you can have vertigo, pressure pain, pulsating temple, pale complexion, diarrhea, dizziness, neck pain, difficulty in thinking, concentrating. So migraine can have vast symptoms, and sometimes they can take you away from the diagnosis. In fact, a lot of people realize today Meniere's disease is a migraine continuum. So primary purpose of history and physical examination is to rule out secondary headaches. Very few headaches are secondary, but they contain most life-threatening conditions. And you must examine fundus and pupil, eye movements, meningeal signs, supinated drift and plantars. Always remember, all that hurts in headache is not just migraine or tension type headache. It can be meningitis, space occupying lesions, ophthalmic systemic causes and primary headache disorders. What are the red flags in diagnosis of migraine? Systemic symptoms like fever and weight loss. Neurological symptoms and signs. Onset sudden. Old age more than 50. Prior history is not there. New headache and secondary illness like AIDS and cancer. Headache expert diary says most common type of headache is migraine. Migraine originates deep in the brain and it leads to inflammation of trigeminal nerve. which leads to dilation of superficial temporal artery, which causes throbbing in migraine. So that is what we have. And there is, if you see this is the diagram of migraine aura. There is cortical spreading depression causing the aura to come like a curtain on the scene. And then it lifts off like a curtain. This is the difference between migraine aura and TIA. So when do you do a CT or MRI in headache? Do all patients with CT and MRI need a CT? Migraine or headache need CT? MRI? No. In fact, if you don't do a MRI in a person who has 5 years headache, you are still medico-legally safe. I'll tell you why. So you must do CT or MRI, and generally MRI brain with contrast. If it is the first or worst headache, subacute headache which is increasing frequency or severity, progressive headache, new onset daily headache, headache always on same side, and headache not responding to your medication. In people who have cancer, who are older, who have seizures, you must always do imaging. If you have systemic symptoms, you have focal neurological deficit, you have edema, cognitive impairment, or personality change, these are the classical indications of doing a scan. And you can find a host of neurological disease on these scans in patients who have these signs or symptoms or these histories. Now let's look at, suppose you were to do a CT and MRI. If you did CT and MRI in patient with chronic any headache and in migraine, your diagnosis will change in 2.4% patients only, which means 97.5% scans will be normal. And if you do this in established migraine for many years, the diagnosis will only change in 5%, 0.5% people. Which means if somebody has chronic headache for 3 years and initially you don't do the scan, you are still okay. But in 30% people, the scan benefits by relieving patients' anxiety about tumor. I must narrate a very good incident. One lady came to me with headache. I did his MRI. I said, your brain is normal. She told her husband, देखो मेरे पास brain है, तुम रोज कहते हो कि तुम्हारे पास दिमाग नहीं है. Doctor भी कह रहा है मेरे पास दिमाग है. So what is the treatment of headache? Treatment, so we'll start with migraine because that's the commonest headache. So it involves 3 things: treatment of acute attack, prevention, and addressing comorbidities. What are the acute treatments? We have oral tablets which are easy to take, but they don't work if there is vomiting. There is nasal spray which is good for patient who is nausea or vomiting. But very few medicines are available as spray and they are costly. We have injections that work fast, but they require needle. The important thing in choosing medicine is how fast it works, how long it works, does it work on the associated symptom like nausea and vomiting? And patient should be told not to wait to take the medication because medicine works the best in first 30 minutes. We have nasal sprays like dihydroergotamine, sumatriptan, zolmitriptan. We have injections like sumatriptan, dihydroergotamine. And we have triptans of various kinds: elatriptan, fluvatriptan, elmotriptan, rizatriptan. The best triptans are zolmitriptan nasal spray, rizatriptan, and elmotriptan. But what are the contraindications to triptans? Known case of CAD or cerebrovascular disease, uncontrolled hypertension, pregnancy, hemiplegic or basilar migraine, and within 24 hours of use. In migraine attack, you can use triptans, NSAIDs, caffeine, naproxen, narcotics, prochlorperazine, ondansetron, and steroids if they are not responding to all the above medications. When do we give preventive treatment? When there are 3 or more attacks a month, single attack disrupts life and work, and it is a patient choice. We have choice of anticonvulsants like topiramate or sodium valproate, tricyclics like amitriptyline, calcium channel blockers like verapamil or flunarizine. We have choice of desvenlafaxine, and we have choice of beta blockers, antihypertensives. If one product does not work, try another. Within the same class of drug or a different class of drug, use side effects. If somebody is obese, give topiramate. If somebody is thin, give valproate. If somebody has BP, give beta blocker. If somebody has depression, give tricyclic antidepressant. What are the recent developments in migraine? You can use Botox, you can use erenumab, you can use lesmitidine. So in migraine, Botox works in about 50% patients, and you have to give 31 injections on various sites. And at our center, a person who takes Botox gets the next Botox free of cost. So this is various sites where you give injection, takes about 5 minutes. Now there are CGRP receptor antibodies which have become a very important medication for migraine, and one such medicine, Suvire or erenumab, is available in our country. It costs about 20,000-25,000 rupees per month, once a month injection. And another medicine called Gpans, Rimegepant, is going to be available very shortly. We are doing the clinical trial for that. Then the newest kid on the block is lesmitidine, which is 5-HT1F agonist. Works directly for acute treatment of migraine. It has no vasoconstrictive side effects, but major problem with this that you have to tell patient not to drive after taking the medicine, limiting its use significantly. If person has continuous headache for more than 72 hours, it is called status migrainosus. It is associated with sterile neurogenic inflammation, or it can be medication overuse headache, and a steroid burst can be used to treat status migrainosus. If patient has intracranial hypertension, benign, you can give steroids. You can give Dimox. And in patient who don't respond to steroid or Dimox, you can sometimes do optic nerve fenestration or VP shunt. But the most important treatment for benign intracranial hypertension is actually weight loss. Weight loss changes the hormonal balance of women, and that leads to improvement in idiopathic or benign intracranial hypertension. The best medicines we used in cluster headache are chronic cluster, we use topiramate, melatonin for circadian rhythm. Short term, you can use prednisolone, or you can use lidocaine and lithium. For surgical options, we can have greater occipital nerve block, occipital nerve stimulation, and resistant cases, we can even do DBS. For acute cluster headache, the best treatment is 100% oxygen, 12 to 15 liters per minute for 15 to 20 minutes. You can take triptans, you can take intranasal lignocaine, and you can take verapamil. There are multiple medicines which have already discussed, which work in various primary headache disorders like beta blockers, CGRP inhibitors, amitriptyline, verapamil, mirtazapine, topiramate, melatonin, lithium. But correction of lifestyle is the most important, and we can use non-pharmacological interventions like CBT, relaxation therapy, exercise, and posture correction. Why do headache treatments fail? Because the diagnosis is not correct. Secondary headache is not diagnosed. Patient has 2 headaches, but only one is diagnosed. Medicine is not used properly. Either the dose is less or the dose is more. Dietary and lifestyle triggers are not addressed. Hormonal triggers are not addressed. Psychological issues like patient expectation, depression, anxiety are not addressed. Medicine should not be dosed too high. The inadequate dosing should not be, the final dosing should not be inadequate. An ineffective dose should not be prescribed, and doses should be combined creatively for best outcome. Take home is listen to your patients. Migraine or headache is a lot of things: sleep, hormones, satisfaction with life, lifestyle. If you do not address the whole problem and you only give medicine, you will not be able to treat your patient wholesomely. Give adequate drug, neither too light, not too much, and be attentive and empathetic to your patient. Thank you so much for a patient list.
You can put your question in the chat box. I'll ask these questions on your behalf.
Dr. Praveen,
Yes, sir.
sir, do you have any experience of using neuromodulation, which is now FDA approved?
Sir, I did not. We use the The REN neuromodulation very frequently, which is called Nerivio device in our country, which is FDA approved. We have done more than 50 cases of neuromodulation. It works in about 50% people.
50%. Okay.
Yeah. Costs about 14,000 rupees for 18 therapies. It can be used both for acute and chronic. For acute, it is to be used for 45 minutes when the headache happens. For chronic, it has to be used every alternate day as preventive therapy.
So, do you recommend the addition of any other medication along with this Nerivio or only Nerivio?
Sir, we do both. See, a lot of people who take that are people who are afraid of medicine or who have contraindication to medicine. It can be even used in pregnancy. But some people, the headache is so bad, one therapy will not work. So
Yes.
there we combine medication with Nerivio.
Thank you.
Any other question?
Praveen,
Yes, sir.
as usual, excellent talk and very short and crisp.
Thank you, sir.
बट वो तुमको याद है जब हम छोटे थे बस अड्डे पे रेलवे स्टेशन पे किताबें मिलती थी 30 दिन में डॉक्टर कैसे बने।
हाँ जी।
तो भाई हेडेक के पेशेंट तो हम तुम्हारे पास भेजेंगे लेकिन हमको प्राइमरी कंसल्टेशन कई बार करना होता है। तो ये जो आज के प्रेजेंटेशन था इसको थोड़ा सुंदर तरीके से लिख के शॉर्ट में हेडेक के डॉक्टर 5 दिन में कैसे बने हम पढ़ लेंगे इसको धीरे धीरे तो थोड़ा अच्छा लगेगा।
सर मैं आपको भेज दूंगा। वैसे तो आजकल इंटरनेट पढ़ के हर कोई मरीज
नहीं नहीं
भी
नहीं
हेडेक का
नहीं जो
डॉक्टर बन
इंटरनेट
गया
में सर्च करना पड़ता है उसमें तुम्हारी
है।
चीज
मैं
एक्सपीरियंस की
आपको
होती है।
भेजूंगा सर। I will
नंबर दो।
send the presentation to Dr. Goyal and he will send it to IMA Haryana, sir.
Thank you. Number 2, have you experienced headache yourself?
Sir, every doctor must have experienced headache some point of time.
Okay, but excellent talk, I must say.
Thank you, sir, for your
Yes,
generosity.
wonderful talk. Very nice.